Well, you ought to be scared to crap of this disease, I'll tell you that. If you haven't seen this one, you're really lucky. And this is unpredictable, rapidly progressing, and untreatable angioedema of the lips, tongue, pharynx, and upper airways, leading to asphyxiation and death from ACE inhibitors.
Well, greetings everyone, and welcome back to the Resuscitation Vcast. And I hope you all have been enjoying the holidays. My name's Amal Matu, coming at you from kind of a dismal day here in Maryland. You can see out my kitchen window. It's kind of ugly. Anyway, this is the holiday season, and so I wanted to bring you a holiday treat, and that is the opportunity to save a life. And who's going to help us with doing that? Well, none other than someone that you just saw. That's the famous or infamous Dr. Jim Roberts. For those people that don't know, or maybe thinking Jim Roberts, that name kind of sounds familiar. This is the Jim Roberts right there. Jim Roberts from Pennsylvania, one of the biggest and most famous emergency physicians probably in the world. And this, by the way, is, in my opinion, the best large textbook in emergency medicine, the clinical procedures in emergency medicine. It is a classic in emergency medicine, and Jim Roberts is still going strong and has a new edition coming out sometime in 2013. It's been through 5 editions already, and he is really one of the experts in procedures and airway management also. One of the things that he has oftentimes written about and talked about is the management of ACE inhibitor angioedema. This is a really, as he said, a really scary disease, and I think in emergency medicine probably the quickest way to die is to lose an airway. Right? That's what ABC stands for, airway, breath, sound, circulation. The mantra of emergency medicine. It's important to note that the A and the B focus on the airway. The first 2 things in our mantra are all about airway. So anyway, Jim's going to spend some time talking about a really scary condition, and that is ACE inhibitor angioedema. He has a lot of experience with this, and as I said, has lectured and talked about this. This is going to be excerpts from a lecture he did at the 2012 Resuscitation Conference in Las Vegas this past spring. And by the way, the next Resuscitation Conference, May 1st through May 5th at the Encore Hotel in Las Vegas. Anyway, back to Jim.
All these pictures are patients I've personally taken care of. You don't want to be at 2 o'clock in the morning, this lady coming into your ER on a stretcher when you're there by yourself. This has got to scare you. This lady is, as I call them, imminently croakable. So you have to be really careful about this. You have to have a protocol. You have to be thinking about this. The bottom line is you don't have a whole lot to help, and you just better be lucky someone else is on that shift and not you. It's in the news recently. For some reason, I think the general public and most clinicians are somewhat clueless about this. You talk to a lot of GPs, and they prescribe ACE inhibitors to everybody. I don't think they warn their patients enough about angioedema. If it is, they don't sort of get it. I can tell you in Philadelphia, we see it in epidemic proportions. It is becoming one of the major lawsuits in our area that you haven't adequately warned patients about angioedema, and they're all on ACE inhibitors. And the New England Journal said it was so unusual that they wanted to publish one of those images on there, but you spend a week in my ER and you will see it. Here's a New England Journal article that came up a couple of months ago, but that ain't easy. And if you think you're going to get an airway in that guy without a whole lot of help and frustration, you're fooling yourself. You can look this up, and very, very scary.
Can you imagine that? Getting a New England Journal publication out of taking a picture of someone's tongue, which we see at least probably, every week. It's inconceivable.
What are the clinical characteristics? Well, it's similar to the angioedema you see with some other of the drugs, but in ACE inhibitors, it's about 0.4 to 0.7%. Well, if you have 1,000 patients in your practice, you're going to see patients who are going to have angioedema from ACE inhibitors. They're all culprit. Even some of the ARBs now have been talked about. Here's the problem. It can occur within the first few days, but it usually doesn't. It usually occurs after the patient's been taking them for quite some time, sometimes for many months to years. The drug's well tolerated, but if you talk to these patients, you'll oftentimes find out they've had little episodes of swelling of the lips, and they thought it was an allergy to food. Why does it come on after having it for a couple of months or a couple of years? Don't know. African American women in my population has it most. Young, generally viable people are affected. lips, tongues, pharynx, occasionally the face. But it does, interestingly, has no peripheral edema. There's no pruritus, right? There's no hives. This is just swelling of the lips and tongue and the pharynx. And the danger of this is right in front of you, they can seem to be blowing up like a balloon. And this is a very, very scary problem. Maybe asymmetrical. Occasionally the genital, but I couldn't find a picture. Bowel wall with abdominal pain. When's the last time someone comes in with abdominal pain, you think they might have angioedema of the bowel wall from their ACE inhibitor? I'm not sure how you make that diagnosis, but the recurrent abdominal pain, someone on an ACE inhibitor.
Okay, I've been writing down some key points, so let's re-emphasize some of the things that Jim's talked about. First of all, ACE inhibitor angioedema can occur unpredictably after a patient's been safely on the drug for several months or even a couple of years. I've seen that myself. It can progress unpredictably and rapidly, and Jim will talk a bit more about that. It mainly affects the oropharynx, the lips, the tongue, the uvula, you'll see that, and it can rarely affect the bowel, hands, and so on, but it's mainly just an oropharynx condition. And the other interesting thing that he'll show pictures of in just a second is that it can be asymmetric as well. You would think that this is a systemic disease, so it's going to affect both sides of the body, both sides of the oropharynx equally. Not so. And so it may mislead you into thinking that it's a local reaction to something, for example, a bug bite. And also another key point is this should not be associated with hives or peripheral edema.
This is what you see. Man, that's scary. Now, this lady is going to die. She needs an airway. There are a couple places to go. You probably can't go through the mouth. You might be able to go through the nose, but if she's on Coumadin and you're mucking around the nose, she starts to bleed. That's not fun. You might try the neck. I dare you to even feel the trachea in this lady. Okay? That's a scary problem. This is one where you share the liability with the ENT surgeon right away. Here's one just of the lips. Patient I saw a couple of years ago, mildly the lips. The lips tend to be the most common initial presentation, but I've seen people come in with no problems except that all of a sudden it was their tongue. And a lot of times they think they don't know what's going on, so they take their blood pressure pills in the morning. He said, it was good. I just was able to get my lisinopril down before my tongue got so swollen I couldn't swallow. So now they've got that on board. Here's the world's largest uvula. This is a keeper. Look at the size of that one. Here's a lady, another one, just a little bit of weirdness underneath the tongue. Nothing else of the tongue or the lips themselves. I've personally seen all these patients. Here's one with asymmetric swelling of the tongue. Here's a guy, unusual Caucasian, with sort of the lips and this area around here. None of these patients had any idea that this was from their drug. Not a single one of them. Here's another asymmetry of the tongue. Here's a guy, asymmetry of the lips. Here's a guy with big lips. Okay, so what do they tell you? Most of them say that they have an allergic reaction. That's common sense, right? Some of them say they're an insect bite. A lot of doctors over the phone, they say, you probably got bitten by a mosquito when you were sleeping. Take some Benadryl, put an ice pack on it, it'll be okay. Sometimes they get a hoarse voice. This is mainly upper airway, so it doesn't go much in the larynx. They say the throat's tight. Some are difficulty swallowing. Shortness of breath is when they get so bad that the tongue has really cut off their airway. The time course, over minutes to hours, and go away. Come back again once you send them home. Asymmetric, you saw that. Once the drug is stopped and you fix them and they stop the drug, they can have recurrences for up to weeks afterwards. Now, I don't see much of this, but that's what it says in the literature. But I have seen one or two patients who I think have had this recurrence. Somewhat difficult to say. Here's the bad news for you guys. It's totally unpredictable what's going to happen during the first few hours. Very unpredictable. You can go to being stable, never getting worse, to decompensating to asphyxia in a matter of a few hours. Sometimes 20, 30 minutes you can actually see it occur. We've seen deaths in a few minutes after they come into the emergency room, go into cardiac respiratory arrest. My sort of non-scientific opinion is, because we see a lot of these, if they're okay for 4 to 6 hours, they're probably going to be okay if they're not progressing, which allows us to maybe sometimes discharge some of these patients, but it's a gutsy move and you have to be very careful. All right? This is why they die. How do you treat it? Well, there is no treatment. That's the bad news that will work, at least in the literature, but I have some suggestions for you. We know that the standard stuff for allergies to penicillin and that sort of stuff, or bee stings, won't work. Now, they don't get anaphylaxis in the sense that they're hypotensive and hives and that sort of stuff. The main goal is also to secure the airway, and you really have either an intubation or a surgical airway as your choices, and then your other choice is, do I want to intubate them too soon or do I want to intubate them too late? That's the same way with asthma, congestive heart failure. You seem to either do it too early or too late. I think I would go for the too soon with this particular disease because it's so difficult to predict, and you have airway problems that you don't have in asthmatics or you don't have it in people that have pulmonary edema. Well, do drugs reverse it? Everybody gets the drugs, but they don't work. No proven benefit of epinephrine, any of the antihistamines, or corticosteroids. And I can tell you, all our patients get them. I've never seen it have anything to do with the case, but we still all give them because we don't know what else to do. People have also tried anti-leukotrienes, cyclosporin, immunoglobulins. No help.
Okay, let's stop for a second again and sum up some of the key points that he's mentioned in the past few minutes. First of all, might consider discharge of these patients if you've observed them for at least 4 to 6 hours and there's no progressing symptoms. That's really something that we do if the symptoms are number 1, mild, number 2, if we've watched them for, say, we tend to watch them for at least 6 to 8 hours and there's no progressing symptoms. And also, number 3, if they tell you that they have not had a recent dose of the medication. So, for example, if they say the last time they took the medication was last night and now it's the next morning, then I feel better about that. But sometimes they'll come in and say, yeah, I took my dose of medicine just before coming in, and then that 6 to 8 hour observation is kind of out the window. I don't know how long to observe them. We'll probably keep them around for a lot longer than 6 to 8 hours. Second key point, you need to intubate these patients early. If they look like they're getting worse, you intubate them while you still have a shot. Nasotracheal intubation if necessary, fiber optic, whatever you can do, get these patients intubated before you lose every trace of airway. And also the usual drugs that we use for most allergic reactions, the H1 and H2 blockers, the steroids, the epinephrine, those don't work because this is not an IgE-mediated allergic reaction. I'm not saying don't use them, and most of the guidelines say go ahead and use them, but they don't work. So give them anyway, and maybe you'll get really lucky, but usually they don't work. There is an antidote, however, pay attention, he's going to talk about it next.
Fresh frozen plasma is the only potential antidote that I know of now. 2 to 3 units. There's just a couple of cases. It takes about 20 to 30 minutes to get it. This has been recommended for 10 years. Fresh frozen plasma treatment of resistant angioedema. This is 2004. Here's one in 2002. Now they're case reports, but they had remarkable changes. Okay, but I don't know why doctors don't do it. Here's Medscape 2012. Still have the epinephrine in there, by the way. Fresh frozen plasma in Medscape. Try to defend why you didn't give it in that particular case. And this is from an article in 2002. So 10 years ago, fresh frozen plasma was being suggested. Potential therapies on the sideline. You get mailings for this. Ecallantide or Calbitor. This is used for hereditary angioedema. Costs $10,000 a dose. And the initial studies are underway for this ACE inhibitor angioedema, and it appears to be a remarkable antidote. Seems to be absolutely fantastic. They can't keep people in the hospital long enough, according to the drug company, to follow them after they got this antidote because they leave. They said, I'm better, doc, I'm out of here. So this is something on the horizon. Here's another one, a bradykinin receptor called, I don't know, maybe this name up, Firazura or something like that. Ecantabid. None of these are available yet in the United States. When this stuff comes out, we're probably going to use it.
Well, $10,000 seems like a lot of money for a dose of medication, but I'll tell you, it is 100 times less than the amount of money that was paid out in a lawsuit that I know about for ACE inhibitor angioedema, where the emergency physician was unsuccessful in securing that airway, lost the airway, patient died. Over $1 million. So give it some thought.
When to intubate? How about minor lipedema? Well, I must admit I do not obviously admit everybody comes in minor lip edema. We watch them in the ER 6 hours after the last dose. These drugs are given twice a day, so if they're not progressing, generally we'll send some of these patients home. Again, they all get the cocktail of the drugs. I think it's treating us more than anybody else. Once the tongue is involved, be very careful. Very hard to send somebody home with any tongue involvement at all, even if they just say it's big or it feels big to them. Sometimes they have some sort of garbled speech, but I would not send somebody home whose tongue is swollen. Now, I don't necessarily have to intubate those patients, but they are admitted to the intensive care unit, not to the floor of the step-down unit. I've been personally involved in 2 malpractice cases where the patients were admitted to the floor and they rapidly progressed to airway occlusion, not known on an airway floor, so that it wasn't picked up. Admit these patients to the ICU. Takes up an ICU bed where you keep them in the ER, but what you're dealing with is something that is totally unpredictable. This is not an easy intubation. There's no time to be heroic, no time to say, I can intubate anybody. Ask for help, get a protocol that shows you that had all the players' involvement. We call anesthesia and ENT, and if they're not imminently crocable in the ER, they go to the OR, where they're out of my hands and I'm off the chart totally. Care turned over to ENT and anesthesia. I always like that one there. Here's some protocol suggestions. Here are the people you want to involve. Intubate in the OR if you can. These are issues that you need to talk about. Sedation, these people, you don't want to sedate them because you don't have an airway. You obviously can't paralyze them. I like ketamine for this. Ketamine allows them to continue breathing. There's a little bit of problem sometimes with a little bit of foaming of the mouth, which is not a big problem. Anticipate a surgical airway. Consider your special stuff. Get the appropriate backup. Ketamine. I prepare the nose. Neosynephrine. You put a nasal airway down there, so if someone's going to have to go through the nose, at least you have some anesthesia in there, and you've shrunk down the mucous membranes. A lot of times you don't have any time to do that.
Well, ketamine and neosynephrine are 2 drugs that are definitely worth having on hand. Next, Jim's going to finish things off with a nightmare case that he had to deal with, and I think it really pulls together all of the concerns, the problems, and sometimes the luck that you need to manage some of these airways.
We're trying to do this fiber optic scope, 100% oxygen. This was done without any anesthesia. These guys, I had to personally give some ketamine to this lady because she's yelling and screaming. And here's your tube on top of the scope. This anesthesiologist, who's one of the best in the hospital, could not snake this scope into the larynx. Too many secretions. The lady was flopping around too much, and I thought we were going to die. This is a little closer view of her. You want to try and find that trachea? Not me. How'd you like to be that patient and being awake? Holy cow. So what we did was made the incision the wrong way. They obviously didn't read my book, but what we did on this lady, the surgeon was there, first-year surgical resident. Yeah, he's a big help. He actually was emergency medicine resident rotating on surgery. So we were going to cut the neck and try to do a crike on this lady. So what I did is I just pushed the anesthesiologist aside, and I took the nasotracheal tube and put it in her nose, blood all over the place, and just started pushing it in there, and all of a sudden, you'd love to hear that sound, went right in. The emergency's over. But it took 3 or 4 times, just dumb luck that it went in there, but he couldn't do it. And here she is, look at that tongue, whoa, it's the size of a cantaloupe. She would have been dead in another 10 minutes. Scary, scary case, dumb luck, blind nasotracheal anesthesia, and again, a scary case.
These ACE inhibitor angioedema cases are amongst the scariest cases in emergency medicine. Patients come in awake and alert, and then over the course of several hours can quickly lose their airway. There's just nothing worse in emergency medicine than somebody who's acutely losing their airway when you're not able to get the airway through standard means. So my thanks to Jim Roberts for sharing his expertise with us at Resuscitation 2012. And I want to put a plug in for his book again. This is a classic book. Most of you probably know about it. The Robertson Hedges Clinical Procedures textbook, and a new edition should be coming out in 2013. And also put a plug in for Resuscitation 2013. We'll be back in Vegas at the Encore Hotel with some great speakers once again. Check out the website, www.resuscitation-conference.com. May 1st through May 5th. Hope to see you all there. Until then, take care.